much, and I will say welcome to this webinar organized by Posithiva Gruppen's Knowledge Network for Women Living with HIV. Both chronic and neuropathic pain is something that we often hear people talk about amongst our members and other people living with HIV. And I think there are many here today who are looking forward to learn more about this topic. And I would like to introduce our first speaker, Professor Jessica Merlin. She's a professor of medicine at the University of Pittsburgh. She's the director of the Challenges in Managing and Preventing Pain Clinical Research Center, a physician and a behavioral scientist. And Posithiva Gruppen first learned about Jessica Merlin's research when we had her presenting at the AIDS Impact 2023 conference last summer here in Stockholm, a conference which Posithiva Gruppen was the local organizer of. So we're really happy to have Jessica Merlin with us here today, where she will talk more about her research in HIV and chronic pain, interventions and how to manage chronic pain. So welcome, Jessica Merlin. So we'll see here, just see that the video.
Yes, I'm so sorry. Can you hear me now?
Yes, we do hear you. Thank you. Welcome.
Wonderful. Thank you so much. It's wonderful to be here. And I'm working on my video here. Hang on one second.
No.
Wonderful. Thank you so much. And thanks for the kind introduction. Yeah, so I was at AIDS Impact in Sweden. It was really wonderful to be in your country, meeting so many of you and learning about you and your HIV community. And I'm delighted to be here today to talk to you a little bit about some of the same things I spoke about in Sweden, just specifically the state of chronic pain in people with HIV from a scientific perspective, and some of the cutting edge research in this space. So I realize that you know, I'm a scientist, and I'm not necessarily always the best at translating from some of our scientific talk to talk that makes more sense for a lay audience. So please, if I'm saying anything that needs further explanation, that is my fault, and let me know. I have the chat open on my phone, and I'm happy to answer questions and also engage in conversation. There's clearly so much expertise in the audience in terms of lived experience. So would love to hear from folks. Feel free to either unmute or just drop in the chat. Yes, perfect. Okay, so yeah, next slide. Next slide. Okay, so first, yeah, we'll get everybody on the same page talking about just some chronic pain basics, and then we will do a brief scientific review about what the literature tells us about clinical characteristics of chronic pain in people with HIV, epidemiology, pathophysiology, just you know how chronic pain comes about in people with HIV, and then think together about treatment, including a particular intervention that I presented at AIDS Impact called Skills to Manage Pain. Next slide. Okay, so chronic pain basics. Next slide. So when I say chronic pain, what do I mean? So chronic pain is pain that lasts for at least 3 months beyond the period of normal tissue healing, meaning that, you know, sometimes people have, let's say, an injury, or so maybe they break a bone, or they have a chronic condition like arthritis. And when that immediate inflammation from the arthritis or the injury goes away, their pain goes away. And for some people, that doesn't happen. For some people, the pain persists even when there isn't that, you know, initial tissue damage still going on. And some definitions of chronic pain also include that it occurs most or every day. And then there's this concept of high impact chronic pain, which is chronic pain that is really limiting somebody's daily life or work activities on almost every day. Next slide. So there aren't great global estimates of chronic pain prevalence, but in particular, these numbers are from the US. So overall prevalence of chronic pain in the US is 20%, high impact chronic pain is 6% in the general population. Next slide. So I really want to encourage people to think about chronic pain, not necessarily as a symptom of something, which is often how we as medical professionals are taught to think about chronic pain, but rather as its own chronic disease in and of itself. Because maybe when pain starts, it's a symptom of something, but when you have pain that persists beyond the time frame that's expected, there are unique biological factors, also psychological and social factors that perpetuate chronic pain and keep it going. So for example, chronic pain can cause depression. Depression can make chronic pain worse and keep chronic pain going. The same thing can be said for social isolation. There are also biological mechanisms in the brain and spinal cord that we know continue to process pain signals even beyond that initial tissue injury period. And we know that chronic pain is associated with substantial disability. So taken together, these things really mean that we should be thinking about chronic pain as its own problem in and of itself. Next slide. And broadly, chronic pain management usually consists of a combination of sometimes medications, although we know that some of the medications that historically have been used for chronic pain, particularly in the US, like opioids, don't really work that well and have significant risks. But there are other medications like SNRIs, so basically a close cousin of typical antidepressants, things like duloxetine, gabapentinoid, so gabapentin and pregabalin for specific types of chronic pain. And then there are things that are not medications that we often use, like cognitive behavioral therapy, acupuncture, yoga, exercise, manual manipulation like massage, essentially, and mindfulness. And in the US, those can be harder to access and are often not available to people as readily. And really, the ideal treatment for chronic pain is what we call multimodal therapy, where we personalize and combine these different things together to create a treatment plan for somebody. And the standard of care is really the gold standard is really to have clinics that can provide all of those things. But those are often not widely available, those types of clinical settings. Next slide. So now we'll turn to talking specifically about chronic pain in people with HIV. Next slide. So why do we want to talk about chronic pain in people with HIV separately from chronic pain in people in the general population? Obviously, I probably don't need to make this argument too strongly to this audience because you all really appreciate these things very keenly. But I think it's worth saying that there are probably some unique things about the biology of chronic pain in people with HIV, which I'll touch on in a moment. And the other thing is this, what we would call the psychosocial milieu is different in people with HIV than the general population, right? We know that people who live with HIV can be more socially isolated, can suffer from higher rates of mental health challenges and substance use, not universally, of course, but these are just things that are more common. And so those are also things that impact chronic pain. And so it certainly also stigma. We know that there's stigma associated with chronic pain. Of course, we know there's also stigma associated with HIV. So these are things that can be important. And to some degree, treatment settings. So I have to admit ignorance about the way that treatment settings are set up in Sweden for people with HIV. In the US, we have something called Ryan White funding, which is basically enables the establishment of clinics that are kind of one-stop shops for care for people with HIV to get both their primary care, their HIV specific medical care, and then a whole host of other things, including mental health care, substance use treatment, if that's indicated, social work, case management therapy, all of these different types of things. And so that provides a unique opportunity to develop and test and implement interventions in those types of settings. Next slide. So in people with HIV, of course, peripheral neuropathy has been classically described. So both from old medications that we don't use anymore, but some folks may have lifetime experience with, like the quote unquote D drugs, and then like DDI, DDC. And then in addition to that, there are certainly other medical problems that can more commonly occur in people with HIV that also can cause peripheral neuropathy, things like diabetes, alcohol use, and then we know, of course, the virus itself can cause peripheral neuropathy, right? So, so that's the classic pain condition that people think of. But you know, in 2024, what's just as common is musculoskeletal pain. So things like low back pain, other regional musculoskeletal pain syndromes, things like hip pain, knee pain, shoulder pain. And then there's people who have what we would call multi-site pain, where people have pain in more than one location. There's something called chronic widespread pain, where people have pain somewhere along their neck or back, on the left and right side of their bodies, and above and below their diaphragm. So, and you know, some people have sort of the most extreme version of that, which is called fibromyalgia, where people kind of feel fluish all over. And so, so yeah, so in this current era, we see a lot of musculoskeletal pain and still see peripheral neuropathy, of course. Next slide. Oh, next slide. Oh, there you go. Thank you. Oh, and I already said this, multi-site pain can just be very common in people with HIV. These are some studies that suggest that, for example, median number of locations of pain was 5 in this slightly older study, and then in a more recent study, around 20% of people had pain in more than one location. So it's, you know, often very complicated type of chronic pain to have. Next slide. Okay, a little bit about epidemiology, meaning sort of, you know, how often do things occur, and what are the things that are associated with chronic pain and HIV. Next slide. So I keep saying this, so it's just a really important point to hit home, that chronic pain is an important problem in and of itself, or as we say in the medical community, a comorbidity in people with HIV, for two reasons, I think. So one is how common it is. So there aren't any good directly comparative studies that look at people with HIV and people without HIV to compare how common chronic pain is. But the rates of chronic pain in people with HIV in existing studies span anywhere from 25 to 85%, depending on the specific population that's being studied, which seems higher than the general population, even though, as I said, there aren't studies that directly compare the two. We also know that chronic pain has a negative impact on a lot of important outcomes that we care about in people with HIV. So certainly in the scientific community, there's always lots of focus on retention in HIV care and virologic failure. Also very important, physical function, healthcare utilization. People with chronic pain may end up having to utilize the emergency room, urgent care more, may have less ability to adhere to antiretroviral therapy, be people are likely to use substances that in the very short term may feel like they help their pain, like heroin or fentanyl, and may have less optimal patient-provider engagement. Next slide. Something else to keep in mind is that in the US, opioids are commonly prescribed for people with HIV. I realize that that may be a pretty sharp contrast to the rest of the world. But I think it's sort of interesting to at least know about that. In the US, these are meds that we use commonly, even though there isn't a really strong evidence base for them. And we certainly know that they can lead to opioid misuse, opioid use disorder, and just other side effects of opioid medications, like falls and depression, constipation, and things like that. But sometimes I think doctors, you know, and nurses who prescribe feel like there may not be a whole lot else that they have in their toolbox, not because there aren't other evidence-based treatments, but maybe just because access isn't very good. And so sometimes the most expeditious thing is to write a prescription. That's sort of our culture here in the US around opioids. Unfortunately, it's changing, but still not uncommon to see it. Next slide. I'm going to skip this slide just in the interest of time. So we got started a little late. Okay. Pathophysiology, just because I think, people will often ask, is there something different about the biology of chronic pain in people with HIV than the general population? And can that help us identify treatments that may be specific to people with HIV who have chronic pain? And there's not a ton of literature in this space, but what there is, I think, is really interesting and certainly very thought-provoking for future work. So I'll show you this just briefly. Next slide. So there are animal studies that suggest that GP120, which is a protein on the surface of the HIV virus, as some of you may know, can lead to increased basically pain processing and pain sensitivity, meaning that, if somebody feels a painful stimulus, let's say somebody, let's say you pinch your skin, people who may have GP120 floating around may be more likely to perceive that as pain, whereas people without GP120 floating around may be more likely just to perceive that as a nuisance, right? So that's the idea of pain sensitivity. Next slide. So, as I mentioned a moment ago, there's often this question of, do people with HIV, because of GP120 and other factors, have biological mechanisms that distinguish their chronic pain, and is that why chronic pain seems to be so common in people with HIV? Or is it that chronic pain is kind of at the nexus of other comorbidities like depression, anxiety, PTSD, substance use, and HIV can also be at that nexus, for sure. Not always, of course, but it can be. And so is it just that people with HIV are just more likely to have chronic pain because of these other health problems? Probably the answer is a little bit of both. Next slide. So in addition to pain sensitivity from GP120, we know that inflammation, so like inflammatory markers, are a known contributor to, for example, cardiovascular comorbidity in people with HIV. You may have heard people talk about this over the years, that even when people have suppressed viral loads, they can still have increased risk of cardiovascular disease for this reason, that there's still sort of increased inflammation, even when there's good virologic control. Next slide. So here's a study that we did where we compared basically markers of inflammation, which are listed there on the left, that are common in people with HIV, and also separately in people with chronic pain. We compared them in people who, these are all people with HIV. So everybody in this study had HIV, but we compared them in people with HIV who had no pain at all to people who had chronic widespread pain, which I defined before. So if you think about that as like the worst possible kind of chronic pain. So really trying to see if there was any signal for any of these markers of inflammation. And what we found, I think if you hit next, it'll pop up there for you. Little animation. Okay. Very slow animation. There we go. IL-1 beta was higher in people who have with HIV with chronic pain versus people who don't have chronic pain. That is that IL-1 beta has been implicated in other neurologic complications of HIV. And so so this was a really interesting finding, and makes you wonder whether treatments that address IL-1 beta specifically may be helpful. Next slide. Back to pain sensitivity for a moment. So I give that example of a little pinch. So this is a way to do that kind of testing in the lab, believe it or not. I remember when I first learned about these types of studies, I was really like a little bit sort of horrified that that this is something that people do, but actually it's nowhere near as bad as it sounds. Basically, we have a lab where people can go and get pain testing, where they, it can be testing based on cold or heat or pressure. So very, very small amounts of these like painful stimuli are applied. Basically, in this one, it's heat. So there's a little heat sensor that goes on somebody's skin, and it heats up very, very slowly. And we ask people to tell us when that goes from being uncomfortable to being painful. And when it goes to being painful, we stop and we measure how much heat is being delivered. And so what we can see here is that this was a study of people with HIV who had viremia, so people with HIV who had virus in their blood, versus people with HIV who were undetectable, versus people who did not have HIV. And what we saw was that these three groups separated pretty nicely, so that you can tell that people with HIV who have virus in their blood were more pain sensitive than people with HIV who didn't have virus in their blood. And those people with HIV who didn't have virus in their blood were still more pain sensitive than people who didn't have HIV. Again, maybe because of GP120 or other things that we don't fully understand yet. But again, this makes it seem like there's something biologically distinct going on here. Next slide. So, certainly there are some important next steps in this space. It, I think, would be an interesting question to ask whether there are other factors that interact with pain sensitivity in people with HIV that are not biological per se. So things like stigma, and then further exploring this inflammatory molecule called IL-1 beta, and whether maybe using agents that block IL-1 beta, which are commercially available. Some of them have a lot of side effects. They're not necessarily things you want to take on the fly. They're very serious medications, but there may be others that are more specific and not as toxic. And so should we be looking into these things for treatments for chronic pain in people with HIV? Next slide. Okay, so on to more specifically talking about treatment of chronic pain in people with HIV. Next slide. So we did a study that was published in AIDS Care, which is the AIDS Impact Conferences Journal. So thank you, AIDS Impact and AIDS Care. Actually, it was two studies actually published separately, where the first one we had convened a panel at, panel's not quite the right word, but like kind of a working group at an AIDS Impact Conference, where we had experts in HIV and pain, both people with lived experience and people who were, our scientists in the field, clinicians, to try to get a list of research priorities. And then we disseminated that list of research priorities broadly to people living with HIV around the world, and asked people to help us prioritize them. So treatment was one of the top priorities identified by that working group task force. And then among the top priorities, it was the top priority in that patient survey, not surprisingly, which, I think I'm really grateful to be here today talking to you about pain. I think pain gets nowhere near enough airtime in HIV spaces, scientific spaces. And it's such a disconnect with what people who are living with HIV are telling us is most important. So that's we really need to change that. Next slide. So for a treatment perspective, what has been studied to date? So I gave you kind of an overview of what types of interventions are used in the general population, but because of all the things that are distinct about pain and HIV, it's important to also study treatment specifically in people with HIV. So this was a systematic review that we did a few years ago now, where we looked really broadly in the literature to try to see what's out there. And there was very little out there. There were 11 studies total that we found, and 7 were medication studies, 4 were non-medication studies. The medication studies were mostly heavily industry-sponsored studies, which, those come with their own significant biases. And then of the non-medication things, so 2 studies on cognitive behavioral therapy, one on hypnosis, one on cannabis. Those were unfortunately all very small studies, and there were only 2, and with a lot of flaws. There were only 2 studies that kind of met standard for what we consider in the scientific community to be the best kind of study to do, which is a controlled trial, randomized controlled trial. There are only 2 of those. One of capsaicin, which I don't know if you guys have ever, if anybody in here has ever tried capsaicin. It's like, chili powder from chili peppers. And it can work. It's specifically just for neuropathic pain. It's not for anything else. And it really burns. So it's not a perfect treatment by any stretch of the imagination. You usually have to put on a numbing medicine before you can even put the capsaicin on. So that's not going to change the world, unfortunately. And then cannabis, which we could talk forever separately about cannabis, but unfortunately, both of those studies of capsaicin and cannabis, while they were controlled trials, they were very short-term follow-up. And so, still not very high quality studies. Next slide. We also took a look to see what studies have been published since then. And there really hasn't been a lot since 2018 when that systematic review was published. There's one study adding a physical therapist to a team, an HIV care team, and referring to physical therapy. And another study, there's one additional behavioral intervention that was a very high intensity behavioral intervention, a pretty complicated behavioral intervention. It had a lot of positives, but I think that was its main negative. And it showed some improvement in pain that went away pretty quickly. And then a few small pilot studies of these various modalities, CBT, Tai Chi, and a text messaging study. So to sum it up, there really hasn't been a lot out there in the treatment space for pain and HIV. Next slide. So what kinds of interventions do we need? So as was mentioned during my introduction, I'm a behavioral scientist. So my bias is always that behavioral interventions can be very helpful, but we know from the, we know from the general chronic pain literature that behavioral interventions in the general chronic pain world are really the gold standard. They're the most effective, lowest risk, and if you design them right, they can be implemented pretty broadly. The idea is, to combine behavioral interventions with other things in a multimodal care plan. So this doesn't preclude people from being prescribed medications if that's appropriate, or engaging in other types of therapies, but not having a behavioral intervention for chronic pain tailored to people with HIV is like a really missing link in this space. And so in terms of what type of behavioral intervention, so you may be familiar with something called cognitive behavioral therapy, or CBT, which is a type of intervention that helps people basically build skills around change. It builds skills around ways of thinking about chronic health conditions that can help people improve their function and reduce symptoms. In particular, in chronic pain, we know that when people build skills around, for example, mood and pain, or physical activity and pain, it can actually block the pain signals from getting from people's bodies to their brain. So pain ultimately is perceived in the brain. It can come from the body, but it is perceived in the brain. And so CBT is a way to dampen down that perception and allow people to have less pain and also be able to do more. And so there's a way of delivering cognitive behavioral therapy called pain self-management, where instead of having to have, a very highly PhD trained psychologist doing the intervention, it can come from somebody who's trained specifically in pain self-management, who might be a social worker at a clinic, or a nurse, somebody who's a good communicator that is typically found in HIV care settings, and is specifically trained on a pain self-management protocol. In the US, we have a national pain strategy, and pain self-management is really highlighted as a way of getting this type of behavioral treatment out to the masses because of how it's able to be kind of put into a manual and picked up by frontline clinic workers. Unfortunately, to this point, there really hasn't been much on behavioral interventions in general, which I just discussed. And also, there really hadn't been anything on pain self-management. It had all been these kind of more complex, high burden interventions that are kind of impractical, not feasible in HIV care settings, or really any primary care setting. Next slide. So enter STOMP. Next slide. So this is the cover of the STOMP manual. So STOMP, which stands for Skills to Manage Pain, is a pain self-management intervention for chronic pain specifically tailored to people with HIV. And I won't bore you with all the basic behavioral science. Even many behavioral scientists get bored by me talking about the basic behavioral science piece, even though I'm nerdy and think it's fun. But basically, it's, you know, a very kind of rigorous process of talking to people with lived experience, so people who have HIV, and trying to understand, of existing pain self-management interventions, what components make sense in this population, what components should we amplify, what components don't we need, and in addition, using basic behavioral science theory of behavior change to understand how can we incorporate those theoretical concepts into the intervention in a way that makes sense. So for example, most people probably have some kind of experience with interventions where it's a group of people trying to change something, improve their health in some way. So like in the US, a lot of people do something called Weight Watchers, right, to try to lose weight. And one of the great things about Weight Watchers is it gives you a community of people. You're all trying to do the same thing. And there are some people in that community that are, a year ahead of you, and they can tell you about all their successes and all the things that they struggled with. And that to be a very effective way to help people change behavior. Is that we call that views, was that people really wanted to have a community of other people with HIV and chronic pain, because they often didn't know other people with HIV. They certainly didn't know other people who had HIV and chronic pain. So it made them feel quite isolated. And so we use that as an opportunity to say, okay, let's build a group element of this intervention where people can get that sense of social support and community while also being able to get some modeling. So we include in that group somebody that we refer to as a peer, who has HIV and chronic pain and is doing well and is a good communicator and can talk about their experience and share their experience and facilitate a group of people who are all going through the intervention together. So that's sort of a little bit of how we, the type of thought process that went into designing this intervention. Next slide. Oh, next slide. Oh, thank you. So when it was all said and done, this is what the intervention looked like. So these session topics are pretty typical topics for pain self-management interventions, or even just, self-management interventions in general. Self-management interventions come from the chronic pain literature. There's diabetes self-management interventions, other chronic disease self-management interventions that are out there, in addition to pain.
Sorry,
and so,
Jessica, just 1 second. I just wanted to let you know you got like 3 minutes left. Thank you.
Oh, yes.
Just so you know.
Sorry. Oh, I didn't realize that. Thank you. Oh, thanks for telling me. Okay. So all good. So basically, just you can sort of see the types of sessions that are in this intervention. So things like, in addition to pain education, sleep and pain, mood and pain, thinking differently about pain. We have the group, the peer facilitated group. We have the one-on-one skill building sessions with these topics. Next slide. I'm just going to cut to the chase and say we tested this intervention, next slide, in a big randomized trial, the largest of its type. And we looked at, next slide, just get to the results slide. Next slide. And what we found is that after delivering this is a 12-week intervention, immediately after the intervention, pain was better and the impact of pain on function was better, more than what we see in trials of drugs, including opioids. So basically 1 on the 0 to 10 scale. So that was very exciting. And then next slide, which is the 3-month outcomes, we see that it persists at 3 months post, and we are just looking at data at a year, and it looks like we even see a signal at a year, which is impressive, I have to say, for a pain self-management intervention with no booster sessions or anything. Next slide. No impact on HIV outcomes. That was not what the study was designed for. So it's not surprising that it didn't have impact on HIV outcomes. Plus, most of the people in the study were already virologically suppressed, highly adherent. So next slide. And very cost effective for those who may be interested in that. We're working on that paper is under review right now. Next slide. So our next step is to try to implement STOMP in HIV clinics around the US and to study how to basically strategies for how to implement STOMP in HIV primary care settings in the US. And if folks are interested in talking about what this looks like internationally, please contact me. Next slide. So we are done. So chronic pain is common and important. I don't have to convince you of that. And behavioral interventions are key. And the next stop is implementation of STOMP. So I'm sorry that we had so many technical issues at the beginning. We don't really have much time for questions, but questions, comments, concerns in the last 60 seconds.
No worries. And thank you so much, Jessica. It was such an interesting presentation. And I'm thinking we might have a couple of minutes in the end if someone has any question in the audience. And with that, I will jump to the next person, which is a longtime activist and author, Ophelia Haanyama. She has worked in the HIV field for decades, and now she's actually one of my colleagues here at Posithiva Gruppen. Me and Ophelia will talk a bit about her personal experience when it comes to living with HIV and neuropathy. So welcome, Ophelia. You're with us from London.
Thank you so much.
Thank you. So we'll jump right into it. As a long-time survivor, you struggle with chronic pain and specifically neuropathy or nerve pain. So could you please tell us a bit more about your experience?
I thank you so much, Jessica, for the presentation. I have lived with HIV for almost 40 years. So I started taking ART a few years ago. And I think one of the drugs I took earlier in the late 90s, stavudine. So I sort of developed a sort of extreme persistent lactic acidosis, which is like producing too much acid in my legs. So I have like pain 24/7. My treatment for the pain is I take some antidepressants at a very low milligram. So I'm taking like 10 milligrams of the drug called Saroten in the evenings, because if I take it during the day, I'll be tired all day. So the question is sleeping well or not sleep at all and live with the pain. So I've had it for over 25 years, I think.
Could you describe that pain more precisely? Like what kind of pain is it you're experiencing?
It's sort of pain, like if you have pains, it's like numbness combined with strange pain. It's not like a headache. It's something you feel even when you're sitting down. It's like you have a lot of pressure of blood going to your legs, if I can explain how it feels like. It's nothing that when you touch, you cannot feel it touching it. So it's inside pain. And sort of feel your legs, you feel your legs all the time, that you have legs. I don't think people do that every time. So I can feel, it's like a cold, strange, painful pain during the day, but at night when I'm relaxed, I get it from my hips, one side of the hip, all the way down to the leg. So I can't sleep on one side of on my left side. I can't actually lie down on it. I haven't done it for like 15 years. So I sleep either on my stomach or on the right side.
Oh. So it's a different kind of pain depending on which time of the day or night.
And I think, what happens is maybe it's the same type of pain. During the day, I'm walking around. So as she said, if I'm doing some kind of exercise, I'm not feeling the pain. I only feel my legs. I feel the numbness. I feel a strange feeling. But when I'm relaxed and lying down, that's when I feel the actual pain. So that's when I take the medication at night. A low dose of something called Stockrane. I mean, a low dose of Sarotane, like a very low dose of it, like 10 milligrams of Sarotane every evening. Then I can sleep.
Oh, could you please tell us a bit more about like how the healthcare has met your problems? Like what response did you get from the doctor? Like you said, you had some medication, but yeah, how did you get there?
I think what in the beginning of the HIV treatment, where I was completely excited to take anything that helped with the HIV specific, without looking at the side effects that were not important then. But few years down the line, I started feeling this strange pain, which was very difficult for me to even explain to my physician, because it's extremely difficult to know if it's real pain or it's just imaginary pain or it's a somatic pain. And then at one point, I really had problems to feel my feet. It's painful, but I can't even feel, like my feelings on my feet are gone. That's when my physician suggested to take Sarotane at sort of 30 milligrams per day, which was too high dose for me. And then we reduced it to 10, what I'm taking now. So it's the explanation of the pain that was difficult for both me and the physician to understand. And that's why the treatment of the pain was delayed, because I also didn't understand what it was, and it came very slowly. It's nothing that just happens like that. It's like very slow feeling that just gets worse and worse. And then it's so difficult to explain actually if it's pain, as I said, or it's imaginary something, or maybe I walked too much, or I did something too, like when you exercise a lot, walk, and so you feel like that the whole day. And at night is worse. Once you relax and lie down, once the nerves are down slow, that's when you feel it more. So I don't know if that helps. Yeah.
Yeah, definitely. So yeah, now you talked a bit about it, but how has the pain affected your life and in general?
I think generally now when I look back, it actually affects my sleep. So I can sort of wake up tired. If I don't take I can't even sleep. If I don't take the Sarotane at night, it will take me a long time to fall asleep. And when I take the Sarotane, then I'll be so tired in the morning. So with the treatment affects me by being too tired, then the pain affects me that I'm not sleeping enough. So I think sort of the results is almost the same from the pain and the treatment of the pain. But what I've done also, I walk like 10 kilometers a day to sort of forget the pain, to get a different type of pain. As Jessica was saying, that once you exercise, your brain sort of focuses on something else. And then you sleep because you have exercised. So I reduce the number of tablets of Sarotane I take. So you sort of have to physically do something, for me, physically do something in order to reduce the Sarotane I'm taking so that I can wake up on time without feeling tired. So I sort of get tired from something else, so I don't feel the pain, even if I have the pain.
So yeah, you mentioned some parts of it now, and also Jessica Merlin talked a bit about this model called STOMP, where there are different methods of self-management of the pain. So have you been offered something like that in the Swedish healthcare system, or is this something that you have came up with yourself, how to like manage it?
No, I haven't been offered a STOMP type of thing in the healthcare, at least not with my HIV physician. However, because the Sarotane made me put on weight, so it was the Sarotane side effects that made me start walking, and then the walking helped me not to feel the pain. So I came up with the idea myself because I put on too much weight. The side effects of the Sarotane that helps the pain, my weight just went up. So I decided, okay, now let's walk. Let's just exercise and see. Then I realized I was taking less Sarotane at night because the pain was, I wasn't paying attention to the pain. I was too tired to feel the pain. So I slept. So that I've told my physician that maybe that's a solution to anyone who is feeling like me. I'm only one person, so it's one cohort. So I don't know if that works. But the STOMP, I'm sure if everyone was offered that, maybe it will help.
Maybe I will actually, Jessica, if you would like to comment on any of these that Ophelia has mentioned. Also, what is your reflection when you hear this?
Yeah, absolutely. Well, Ophelia, thank you so much for sharing your experience, and it's really an honor to be up here with you. And I think, you're, what I'm hearing you describe is basically developing, as you said, your own self-management strategies that have been, have been fairly, it sounds like fairly, I don't want to misstate what you just said, but effective to some degree for you. It sounds like it's still, it reminds me of sort of like a juggling act or a balancing act, what you've described with your pain and your medications and the things that you're doing to try to address it. But you've done an amazing job of figuring out kind of what works for you, and implementing your own self-management program. I think, unfortunately, some people are able to do this, like what you've done, and many people are not as able to do this on their own. And so, and these types of programs, these self-management programs, as you said, they're not broadly available. They're not available in the US either, really, which is why we're trying to do some implementation work to try to get them to be available. Yeah.
Thank you so much.
So, Ophelia, I also wanted to ask you, Jessica talked a bit about pain sensitivity and the relationship between this and HIV. Do you have any reflections on that? Have you experienced this changing? Has the tolerance level changed when it comes to pain?
I think so. I mean, since I've lived with HIV for so long, so I actually don't know what is what anymore. However, I think when I have a headache, my headache, I know that I experience a headache more than if I explain it to a partner or a friend. They really don't maybe think that it's so painful because I have a headache. Or if someone is pinching me, you don't have to pinch hard for me to feel that that's painful. I mean, I at one point I thought maybe I'm imagining it, as I said about my legs, but I've realized that even if I hit myself, like slightly hit myself on something, I'm like, wow. And everyone in my family said, oh, there she goes again, exaggerating that. But I actually do feel it's actually painful. It is. It's nice to hear that there's a research into it. I mean, so I'm not getting crazy, because I thought maybe I'm really imagining it. My imagination is pretty good. But pain is actually real. It's actually real. Thank you so much, Jessica, to put it in a much more researched way. And now I can tell everyone in my family that I actually do feel the pain. So I'm pretty happy. Yeah, I do. I really do.
Yeah, I think you might be sharing this with a lot of people also watching this webinar. Actually, I wanted to check if there are any questions from the audience. I will check with my colleague. No. Perfect. Then we'll just continue. So also, Ophelia, do you have normalized the pain? Have you gotten used to it?
Yeah, I think in a way, it's not getting used to it. I tolerate it. I don't have any choice. It's nothing. It's just part of my life. I have a choice whether to follow what I feel every day. Then I won't be able to do anything. So the whole thing is to manage it in different ways. I don't remember when I didn't have pain. I don't know how it feels not to have pain. So I have no other comparison. I just know that my legs are painful. My hip is painful. I can't sleep on my left side. What choice do I have? I have to sleep. So somehow I think, yes, I'm used to it. I don't like it, but it's part of my life. So I don't know what is worse. I mean, when it was AIDS, I knew it was AIDS. I knew that I was going to die, but this is like going on forever. You don't know how long it will take. So it's nothing I can do. Either take the medication, walk, exercise, get up in the morning, work like everybody else. Yeah, there's no choice really. I don't think so.
Yeah, Jessica, in your presentation, you also talked a bit about the relationship between inflammation and pain. Is it possible, like if you manage to reduce the inflammation in the body, does the pain decrease? Is that possible?
Yeah, that's a great question. And I would say that's a great research question, because I think, that would be the hypothesis, right? If we can do something to reduce the inflammation, I would hypothesize that the pain would improve, but we don't know. So we need studies to look at that, where we give people medications that block that one particular inflammatory marker, IL-1 beta. It would be great to have a trial that looked at that. And I've been talking to a couple of my colleagues through the ACTG, which is a big US clinical trials network, to think about whether there's a way to do a study like that, because I think that would be important.
Also in Sweden, I think also internationally, there's a lot of talk about statins these days, and the effects of statins on both blood lipids and also the inflammation in people living with HIV.
Yeah.
So and also in Sweden now, several clinics are starting to offering statins to all people living with HIV over the age of 40. So could statins have any effect on pain as well?
Yeah, that is a great question. So I would love to know the answer to that. There's a trial here in the US called Reprieve, that you guys may have seen, published. It was published in, I forget if it was New England Journal or I think New England Journal. And so I've been talking to some folks from that study to see if I can try to get some pain data from one of their sub-studies that I can look and, we can look and be able to answer that question, like, do statins reduce inflammatory markers that then lead to reduced pain? I think that would be the way to get the answer to that question. But as of yet, we don't know. It's a really important question.
Yeah, and I think we're looking forward to hear more about this in the upcoming years. It's really a topic that comes back, and we have a lot of questions about it. Yeah. So actually, we're starting to running out of time. 1 hour goes fast. Ophelia, would you like to say something, last few words or a question to Jessica?
No, first of all, I'd like to thank Jessica for the research they're doing. Then I feel a bit more normal. That's not a psychological imagination of my pain. And hopefully that one day we'll be able to get something that helps everyone. So, I mean, some people have worse than me, so they can actually get back to their normal life and do something else about it. Thank you so much. Thank you so much, Ronya, also.
Well, thank you, Ophelia, for sharing your personal experience. I'm glad we had a few minutes to discuss this also, all three of us. And thank you so much, Jessica, for joining us. I'm sure you have a very busy schedule, so we're really thankful that you took the time and joined us today. And thank you for also trying to answer all the questions. It is clear that this topic raises many questions, and there is a need for dialogue, I think, like this between researchers, doctors, and patients. So again, thank you. And we have recorded this, and we will shortly put a recorded version of the webinar on our YouTube channel, so you could see it again. And also, if you know someone who missed the webinar today, please let them know that it will be viewable on YouTube. And we will also publish a written summary on our website, and also in our magazine. And if you have any questions for us, or I think also for Jessica, Merlin, please send them to info@positivagruppen.se. And Posithiva Gruppen, we regularly arrange these kind of webinars, events, and about different topics. So please stay tuned, and we will publish information on our website. But we also do offer support and meeting places for people living with HIV. And we do policy work, and we try to increase public knowledge about HIV and reduce the stigma. So anyone can become a member. For people living with HIV, you can also be part of pointing out where we should do our work. And you could become a member at our website. So please join us for our upcoming events. And thank you so much for watching this today.